So thanks so much, everybody, for being here. It's absolutely fantastic, and there's been so many wonderful conversations already. Absolutely delighted to welcome you to our first annual showcase and lecture. So for those of you who don't know me, my name is Aziz Sheikh. I have the privilege of being the head of the Nuffield Department of Primary Care Health Sciences and also being a Pro-Vice-Chancellor here at this wonderful university. And so on behalf of the department, the division, the university, a very, very warm welcome to you. And I realise that there are colleagues across our collegiate university. There are colleagues who've travelled across the UK to be here today, and colleagues who've also travelled internationally. So wherever you've travelled from, a very warm welcome to this wonderful setting. I mean, it's magical. I'd in particular like to welcome our Vice-Chancellor, Professor Irene Tracy, our Chancellor, Lord William Hague, and of course our lecturer for today, Lord Patrick Vallance. It's absolutely fantastic to have you here, Patrick, and thanks so much for doing this. In terms of housekeeping, and I'll just try and get that out of the way to begin with, this is an old building, as you know. It's a couple of centuries old. There's only one exit. There's no fire alarm planned. So if the fire alarm does go off, just make your way out of this building into the courtyard, please. There are no facilities in this room, so back in the main building, if you need to use those. Be grateful if everybody could just check that your phones are off, please. Please just do that check. And there's no photography during the proceedings. This event is being recorded. It will be released on our YouTube channel in due course. And if you want some photos in this iconic venue, we have Cyrus on hand. So please just do nab him. He's absolutely wonderful. So in terms of the venue, so this is one of the great bastions of debate and free speech, and formed at a time when speech was curtailed in the University of Oxford. So we are in really this cradle of democracy, really. And typically, if you come into this building at other times, these leather seats at the front are arranged in opposition, as they are in the House of Commons, so to give that experience, really. And of course, this place has really created leaders from across the world, and you'll see that if you look at the portraits, if you look at the photos up, and so please do have a look at those. But this place has all sorts of speakers. It's remarkable. So I wonder if you just turn next to you and see if you recognise it. They do get a bit tougher. But recognise this person. And you'll recognise the backdrop, really. So, Irene. Yeah, of course. A brilliant champion of sort of the moral conscience of South Africa, really. The Nobel Prize winner. Okay. Who's that? John Barnes, yeah. God, and Liverpool could do with him at the moment, couldn't they, really? So the brilliant midfielder and winger, Liverpool and England, absolutely fantastic. I love this programme. Yeah. And for the Americans here, it's not Shark Tank, it's Dragon's Den, of course, Deborah Meaden, the great environmental sort of investor as well. Okay. Anybody want to sing? John Legend, yeah, absolutely. I thought I'll spare you from my singing, but yeah, absolutely. Okay. From the elders, Mary Robinson, absolutely fantastic authority and another moral conscience, really. Of course, from Lady Margaret Hall, Malala. Nancy Pelosi, yes. And anyone recognize this guy? Gosh. Yeah, no, authority even at that age. Absolutely fantastic. So great to have you back here, William. Wonderful. So this department is absolutely fantastic. And really, I mean, what I've asked colleagues to do in the department is construct a bit of a timeline of the department. And as you can see, I mean, we really kicked off here sort of 1997. David Ment, absolutely fantastic that David is here. Godfrey Fowler to begin with. Godfrey sadly passed away. But David kind of created this department, passed the baton on to Richard Hobbs. But there is a backstory to all of this as well, and really academic general practice wasn't born in Oxford. It was born at the University of Edinburgh. So that was 1963. And I'm absolutely delighted that Peter Mattison and David Argyle are here representing the University of Edinburgh, because it gave birth not only to this academic discipline, but also to academic public health. So that was 1963, relatively shortly after the birth of the NHS. And then after that, the next chairs that were created were in the Netherlands, in Leuven, in Canada, in Ontario, in Norway, in Oslo. And the first chair of primary care created in England was in Manchester. And then it spread to London, etc. And by 1995, virtually every medical school in the UK had a chair of general practice, save two. Any guesses which those were? It's Oxford and Cambridge, those great bastions of innovation. But now that we've got Irene and Gavin at the helm, we're in a very, very different terrain now. But an absolutely fantastic department, as you can see, and what it's grown into is something really quite remarkable. So this is our portfolio of grants that are live at the moment. 500 or so academic and professional services support colleagues, absolutely fantastic colleagues. We've got a growth rate of 9% at the moment, so we are projected sort of over the next few years to reach 750 people. So absolutely phenomenal. And what we were really proud of was to become the first Athena Swan Gold in this university. Others have followed. There's been a lot of work. We are planning for our renewal at the moment, but absolutely delighted that we've been able to do that. And this isn't anything to do with me. I mean, these are absolutely fantastic colleagues, so I've inherited a wonderful department. So academic general practice is still a relatively young discipline, and really, really pleased that we've got so many of the titans of this discipline in the room with us here today. So thank you for all the work that you've done. We've come on a long way, and actually, I mean, this is the direction of travel. So as I came in, what we did is we undertook a strategic review of the department and created our first strategic plan. So lots of fantastic work going on, and you've seen some of this work in our showcase, hopefully, and please do, if you haven't had the chance already, please do have a look at the posters and the displays. Some absolutely fantastic work going on. So the question was, well, what can we add here? What can we do? And really, what we've tried to articulate, and the strategic plan is in your folder, so please do have a look at this when you get a minute, is what we want is primary healthcare to be really at the centre of health systems, not only in the UK, but absolutely globally. That's what we are driving to do. That is our vision. That needs to be based on robust evidence. So our mission is all around absolutely robust research and innovation and outstanding teaching. And we have a brilliant kind of teaching setup, undergraduate, masters, postgraduate, DPhil level as well. So this is what underpins this. But what we want to do is take this absolutely globally. And so what we've articulated in this strategy is that this is around the transformation of health. And we've identified three sort of meta-level themes across our department. The first, and this is what we're celebrating today, is how can we, at this moment in time, when we know the pressures on our NHS, and we all experience these, how can we ensure that this, the largest academic primary care grouping of its kind in the world, it can do work that is directly policy relevant. We want to strengthen those links with policymakers, do things that matter at this moment in time, issues to do with prevention, reducing pressures on the system. Number 2, we know with universal health coverage agenda linked to the Sustainable Development Goals, every country in the world is transitioning to primary care health systems. We have governments knocking on the door almost every week at the moment. So how can we as a department support that transition, but do it in a way that is respectful? It's built on genuine partnership. It's upskilling colleagues in the process, because ultimately we want them to go and do their own thing, so global primary care. And thirdly, around the sustainability of healthcare. And we're looking at sustainability from obviously an environmental footprint, a financial footprint, but also a workforce footprint. But what underpins this is that we can support growth in the economy through health. This will really contribute to sustainability, and this is what Patrick will be speaking to. So in subsequent years, subsequent annual lectures will take other topic areas, and we are, so watch this space. But before sort of handing over to colleagues now, I just want to kind of mention a couple of final things, really. So in terms of global health, delighted that a number of key developments. So we have the Global Health Network led by Trudy Lang and colleagues, which has just moved into the department. So this is a network of 1 million plus people now across the world, really based on sort of a genuine partnership model. So we have this outreach now, which is second to none across our departments. We have, so those of you who heard me speak last year, we announced an £8.4 million investment from Dr. Sadok Bazrour to kickstart global primary care. But today I'm delighted to report, with the support of colleagues Luke Allen, Michael Kidd, Tanis Walker in development and alumni engagement, Sadok has committed another £2 million to support primary care development, particularly in Francophone countries. So really pleased with that, and we'll be kicking off that work in Tunisia. I was with the Minister just recently, and the Ministers for Health and Higher Education. And as of last week, we, as a department, as a whole, became a WHO collaborating centre for primary healthcare. So thank you to Patrick and colleagues in the UK government for signing that off. So really pleased that that's happened, and Dr. Tedros and colleagues are absolutely delighted. On the sustainability side of things, with colleagues in population health, we are now, as of a couple of weeks ago, also a WHO centre around sustainable food choices. So a lot of really key developments taking place. Now, what we're trying to do is incredibly bold. It's ambitious. We need really skilled voices to help guide us. And you may have seen this story, but we have just announced our International Advisory Board. They will be coming to Oxford, and absolutely thrilled that Victor Zhao, the President of the National Academy of Medicine, is going to be leading that. Some absolutely fabulous colleagues here, and Dame Jenny Harries is in the room today. So Jenny, thank you very much indeed. So I want to now turn to the fact that we've got sort of 4 very short presentations coming up, just to give colleagues a bit of a flavour as to what we do in the department. So 4 wonderful colleagues. So Trish Greenhalgh, in a household name. Trish, a brilliant social scientist, will be talking about how do we sort of engage with technology. We know technology, there's so much interest in this, but how do we do this, and how do we actually implement this in a safe and a scalable way, recognising workflows, recognising the complexity of care. So safe, sort of remote models of care. So what we then will move to is Professor Lee Mi Yu. And Lee Mi, together with Chris Butler, leads our primary care trials platform. This is the only primary care trials platform in the world, really. And what Lee Mi and Chris and colleagues did was developed platform trial capability. So we had this in primary care, and we had this in the hospital settings with the recovery trials, for example. It's a really brilliant innovation, and really pleased that they've just been awarded a £10 million grant from Novo Nordisk to kind of really catalyse that work. So Lee Mi will talk about that. And then we'll turn to Professor Chris Griffiths. Chris joined us recently from Queen Mary's. Did his DPhil here, so he's come back to Oxford, so delighted to welcome him back. So Chris led the evaluation of the low emission zone in London some years ago, but more recently he's been leading the evaluation of the ultra low emission zone. So a major sort of public health intervention, and we'll be reporting on the impacts on children's lung health. And finally, Anthony Harnden. Anthony's a wonderful colleague, been in the department for several decades now. And Anthony will be talking about, Anthony now leads the MHRA, that's the Medicines and Healthcare Products Regulatory Agency, and he will be talking about next generation pharmacovigilance systems. And Anthony was the deputy chair of JCVI, the Joint Commission on Vaccinations and Immunisation, and also the spokesman. So if you recognise the voice, it's from the reassuring voice that you heard on Radio 4's today many, many times, really. So this is what we're about. Part of the reason why we're so thrilled that you're here is that we can't do this alone. There's so much talent in the room. So if anything that you see or hear interests you, you think you can contribute, please don't hesitate to get in touch. We would absolutely love to work with you on this agenda. Trish, over to you.
Thanks, Aziz. Okay, so I'm going to be talking about the work of two research groups in the department, the Interdisciplinary Research in Health Sciences group, which is one I'm with, and Medical Sociology and Health Experiences. Sorry, I've almost lost my voice because I've been teaching all day. Now, across these two groups, we've got a really diverse group of researchers, both clinical and non-clinical, including all these different backgrounds and more. Now, if you're talking the standard currency of grants in, papers out, we're doing well. We've had around £12 million in grant income, which is pretty good for qualitative research. It tends to come in small packets. We've had more than 50 major papers in peer-reviewed journals. Since 2020, we've won Research Paper of the Year 3 times for research on different aspects of remote care. That's Research Paper of the Year for the Royal College of General Practitioners. Now, I've put up the QR codes of some of our recent papers. Oh, thanks. That's very welcome. Cheers. We're also doing well at capacity building with 2 MSCs around digital health, a DPhil program, and an active postgraduate development program. Those are 2 of our master's students presenting their model of a health system. Now, these are some examples of the topics we've been studying, and obviously I haven't got long. We've looked at how people access services remotely, and a lot of that is about the work of receptionists and support staff in channeling people to the right clinician. We've studied remote clinical consultations, most of which occur by telephone, not by video. We have to get that telephone call right. We don't study apps in the narrow technical sense. We look more broadly to study why particular apps were introduced, how people use them, and why people don't use them. And we study remote monitoring of diseases such as high blood pressure or diabetes and many more. Now, our approach to studying these topics has got 4 unique features, really. First, we're, as I've said, interdisciplinary, interprofessional, so we can look at things from a lot of different angles. Secondly, we use in-depth methods, such as ethnography, to build a really rich picture of what's going on. Thirdly, we work alongside patients and the public. Now, that doesn't mean we just have patients on our advisory groups. We also have them as co-researchers. Indeed, we have a program of scholarships where people can apply to get funding to do DPhils in their own illness. And our latest 2 patient researchers doing DPhils are both looking at digital technologies in their own illness. And finally, we've got 2-way partnerships with both policy and industry, so our research is able to respond to the questions that those sectors are raising in real time. Now, I'm going to give you 3 very brief examples of things we've discovered. Firstly, we've consistently shown that new technologies are not plug and play. They often mean major changes to people's roles, their identities. their interpersonal relationships, as well as to workflows within and beyond the organisation. Secondly, even when digital technologies are working well, and especially when they're not, they have unintended consequences, such as increasing the fragmentation of care and causing staff stress. And thirdly, while everyone is very concerned about digital inequities, the patient who doesn't have a digital device, doesn't have the knowledge to use digital, solutions we found are usually provided as one-off workarounds for particular patients. We've got it sorted out for Mrs. Bloggs, but actually that, of course, isn't good enough. Now, we've followed through on these findings. For example, when working with policymakers, we emphasise the importance of work to embed technologies in organisational routines and workflows. Kathy Pope talks about the technological graveyard of technologies that were very promising, but that embedding work didn't happen, and so a lot of money was wasted. We've developed a programme of whole team training using scenarios and personas to strengthen those team relations that are mission critical to delivering remote and digital care. And we're working on ways of capturing the ideas of frontline staff for digital inclusion and making them business as usual for all patients who need support. 3 projects we've just started. We're studying AI scribes, which generate automated summaries of clinical consultations. Another team's looking at how AI chatbots perform in patient triage. And another is developing simulations for team training to reduce techno stress. So in summary, and I'm speaking on behalf of 2 very large research units in the department, with a leading team in the UK for clinically informed socio-technical research in remote and digital primary healthcare. We're growing the next generation of interdisciplinary researchers. Our work is very much policy and practice relevant. We're agile, we're technology agnostic, and we're ready to study whatever comes next on the technological horizon. So now I'm handing over to Limi.
Thank you, Trish. Our journey into the platform trials actually began 10 years ago when the ALICE trial, the trial that delivered from by the Oxford University, the Oxford Primary Care Clinical Trials units, recruiting from 14 European countries, it became the largest pragmatic trials in antiviral treatments for flu-like illness in primary care. Although ALICE was only tested 1 treatment at the end, the foundation that was critical, it gave us the blueprint of what we need to pivot quickly at the start of the pandemic to launch principal and panoramic trials. So it funded by the UK RI and the NIHR and supported by the urgent public health infrastructure and the NIHR research delivery network. These became the most impactful community-based trials globally, proving that we can actually generate evidence at an unprecedented pace and scale. By operating under a master protocol, we created a perpetual trial infrastructure that allows us to evaluate multi-treatment simultaneously, adding new therapies quickly and dropping anything that's actually not effective very efficiently. Both trials together, we recruited over 40,000 participants from more than 6,500 GP practices over 4 years, contribute to evidence on 7 repurposed treatments and 2 new antivirals. So alongside the platform trials design, these trials utilize a decentralized model which allows participants across the UK to join the trials from home. So we achieve this by integrating 4 key innovations, such as having an online registration and screening portal to enable patients to take part in the trial nationally. Using electronic consent system, delivering trial medication directly and patient via post, and also using courier services. using online diaries and linking to healthcare system data to obtain outcomes without requiring any clinic visits. So in 2024, both trials have been awarded the Pre-Gallian Best Public Sector Innovation Award. So after the trials, so what's next then? So the principal trial is actually being featured as a case study for platform trial design in the NIHR DCP training. Also, we'll also be able to apply the design and lessons that we learned to new areas such as the OPAL trial in obesity and also the PUMA trial in early psychosis. Internationally, we're able to also take part in a trial called ECRADE, and ECRADE Prime is the platform trial that we're recruiting participants in 9 European countries, including the UK. So the aim of the trial is to evaluate treatment for respiratory infection in the community. This work is important for the patient's care right now, but also is actually preparing for the pandemic, the next pandemic, if there's going to be any one at all. Hopefully not. Our trial management team has actually successfully scaled up recruitment by leveraging the Be Part of Research service. So this is something quite new for us, but we actually have seen an extraordinary results. So the recruitment has actually increased extraordinarily in an exponential way, and we actually hit the target this week, making us the UK site as the fastest recruiting site in Europe. So our work now contributes to global initiatives like the World Health Assembly Resolution 75.8, which focuses on strengthening clinical trial worldwide. The evidence showed also that there's an impact ranging from the NICE and the WHO clinical guidelines to something that we actually have done quite not recently, but probably a couple of years ago, which is the economic evaluation of molnupiravir in Japan, was helping the Japan to make government to make the decisions about what they actually want to use molnupiravir for. And the next frontier is about moving trials closer to patients, embedding research into everyday care. We're shaping the future of the trial design by championing digital enablement, and also data linkage and a single portal approach for platform trials. Crucially, we're tackling the inverse research participation law to ensure research equity, bringing trials to the community that needs more, that the people need most. By building this permanent infrastructure, the UK will be the most attractive global destinations for rapidly answering critical health questions through perpetual system-strengthening clinical trials. Thank you. And now I'm passing it to Chris.
Thanks, Lily. So in 2019, we published work showing that children in central London exposed to traffic pollution had reduced lung volumes. We found that 5 to 10% loss of lung volume was associated with illegal levels of nitrogen dioxide. These findings were, These findings were picked up by the BBC. So why is this important? Well, this slide summarises trajectories of lung growth from a number of cohort studies, but the important thing to note is this line illustrated by the stars, which shows that children with impaired lung development fail to reach their maximum predicted value by the time they reach adolescence and early adulthood, and then after that they're on a continuous decline. And this puts them at increased risk of major illnesses, COPD, chronic obstructive pulmonary disease, asthma, even cardiac disease, diabetes, and ultimately premature death. So, what can be done? So, after all, prevention is pretty much the key to the survival of the NHS in the coming years. So, at this time, the Mayor of London was implementing the ultra-low emission zone, and this is the largest clean air zone in the world. So, this was an opportunity for us to set up a natural experiment, the CHILL study. And so I'm going to outline the design of that now. So the essence of the CHILL study is that we recruited 3,500 primary school children, half from central London, where the ultra-low emission zone was to be implemented, and half from a comparator site, Luton. And Luton's important because it has a similar demographic mix, similar levels of deprivation, a similar pollutant mix to London. But absolutely, essentially, it does not have a clean air zone. So we're comparing an ultra-low emission zone in London with an area without a clean air zone. And we recruited the children, and we made annual visits to the schools to measure lung function. The first visits were done before the introduction of the ultra-low emission zone, and the subsequent 4 years followed that. So what happened to air pollution? So you can see on this slide we have the 5 years of the study, levels of nitrogen dioxide for the two sites in blue, Luton, and the orange site is London. And the red horizontal line is the World Health Organization's limit value for nitrogen dioxide exposure. So anything higher than that is definitely bad. So let's just look at the blue bars, and you can see that there's a slight decline in nitrogen dioxide exposures for the children during the 5 years of the study. For London children, the nitrogen dioxide levels are massively higher, more than double, but there's a significant step down, as you can see, just after the ultra-low emission zone is introduced in the second year of the study. So against that background of improving air quality in London, what's happening to lung function growth? So again, in this chart, we have the same 5 years for the lung function growth. And the y-axis starts at 1.3 litres and goes up to 2.5 litres. So essentially what we're seeing is lung growth increasing as children get older. But what I want you to focus on now is the first year before the ultra-low emission zone is introduced. And we see here that London children have lower lung volumes than their peers in Luton. And that's exactly what we would expect on the basis of our findings that I reported at the start of the study, because the London children have been breathing dirty air for a long time. And then, over the next 4 years, something quite magical happens. So, what happens is that the London children's lung growth starts to accelerate, and by the time we reach the 4th year, it's reached parity with their peers in Luton. So this is an extraordinary result and evidence that clean air can alter lung development and regain lost lung function. So these changes are strongly associated with the pollutant exposures. So really, in summary, this is a large, robust evaluation of the impact of the world's largest clean air zone. We saw significant falls in nitrogen dioxide, and those are associated with acceleration of lung growth and recapture of lost lung function. The implications are large for these findings, particularly because we can alter children's and regain children's damaged lung development, but also because there are implications for health and wealth. If we can prevent in the future people developing COPD, asthma, cardiac disease, and premature death, then this is a real benefit, particularly for health and wealth for the country as well. So there's not a city on the planet that does not have a problem with traffic pollution. So these findings have relevance globally, and our intention is to take the work abroad and try to replicate these effects in global cities. We've been invited to present the work to the European Parliament, which we've done. We presented the work to the United Nations Human Rights Rapporteur, and a couple of weeks ago I made the lead for the environment for the World Health Organization aware of these results. So this is the CHILL study and a lot of other people involved. Thank you.
I'm delighted to be speaking at our first departmental showcase event. Since being appointed as a clinical tutor by Godfrey Fowler in 1992, I've been very fortunate to work under successive heads of department. David Mant, Richard Hobbs and Aziz, more recently, who are all here today. They have supported me to do both research and policy work, and today I'm speaking about pharmacovigilance opportunities in the UK as chair of the MHRA. At its core, pharmacovigilance is about identifying risks early, assessing them accurately, and acting promptly to protect patients. This matters enormously. Adverse drug reactions place a major burden on patients and the NHS, not only human costs, but estimates of more than 2 billion a year in avoidable hospital admissions. More than 60 years ago, the thalidomide tragedy reshaped how we listen for harm, leading to a system built around spontaneous reporting. The yellow card system remains a cornerstone of the UK pharmacovigilance and has enabled the identification of many important safety signals, but it is, by definition, passive. At the same time, the way medicines are used has really changed. Treatments are much more complex, used for longer periods, prescribed to broader populations than those typically included in clinical trials. Randomized trials cannot, on their own, identify all the uncommon, delayed, or population-specific harms. That places increasing importance on learning actively from real-world use. To do this effectively, we need the right data infrastructure. Many of you in this room were involved in the COVID-19 pandemic. Then, near real-time data enabled daily safety assessments and timely evidence-based advice for clinicians and the public. We were at JCVI able to refine and modify the vaccine programme as we went on. We do need to learn and build from this. The level of responsiveness should not be reserved for a crisis. It should power the safety monitoring for us all. The challenge really is now to make it routine. The 2023 Sadler Review was clear that the UK's health data infrastructure is not yet configured to meet the needs of national bodies like the MHRA. Despite the advantages we have in the UK of a cradle-to-grave nationalised health system, fragmentation, variable data quality, and complex access processes remain barriers. This is why the newly established Health Data Research Service presents such an important opportunity. HDRS can move us beyond a patchwork of databases towards a genuine national capability, one that provides timely, secure, and joined-up access to high-quality health and genomic data. One of the first decisions I made as chair of the MHRA was to take the board to devolved nations. It was clear in Scotland during discussions that they have much better data systems to allow analysis of hospital prescribing and link to outcomes. And we're now working with Aziz and colleagues on a system called Medicines in Acute and Chronic Care in Scotland, otherwise appropriately known as MACS. We are starting with producing safety data for targeted immunomodifying therapies, and this really is to provide a powerful proof of concept for what HDRS could achieve, taking a whole country approach to the analysis of safety data. To move from reactive to proactive safety and surveillance, HDRS needs to provide the infrastructure for an always-on safety system that links across both primary and secondary care. And I think it should make pharmacovigilance one of its early priority use cases. If we get this right, we will strengthen patient protection, support faster regulatory decisions, and make the UK an even more attractive place to develop medicines and devices, promoting health and wealth. This is really something only the UK can deliver. We've already seen the beginnings in Scotland and its blueprint for the HDRS. Now we need to make it the norm across the UK. Thank you.
So thanks very much indeed. Trish, Leamy, Chris and Anthony, absolutely fantastic presentations. So we were the warm-up act. We now sort of turn to the main event for the evening. And Irene, over to you to introduce Patrick. Thanks very much indeed.
Chancellor, Lord Vallance, AZs, dear colleagues, dear friends, thank you so much for inviting me here this evening, and a warm welcome to you all as well. This is obviously a very special occasion and a very special day, and I'm only just sorry I wasn't able to join you for some of the showcasing earlier. But I know, having visited Aziz, the department, over the past year, just how outstanding the work is that goes on. You span prevention, digital innovation, clinical trials, environmental health and global engagement, as well as, of course, your outstanding teaching. And it clearly reflects a community that is ambitious and collaborative and outward looking, and for that I'm very grateful and extraordinarily proud. Thank you to the speakers for sharing just a brief insight into the extraordinary work that you are doing, and to do it so succinctly in the short amount of time that you had. Many interesting elements for us to all reflect on and further discuss a little bit later during the networking. I think it's a great illustration, is it not, of the research that's both rigorous as well as being consequential. And this is Oxford at its best. I'm bound to say that as the Vice-Chancellor here. But yes, academically superb, of course, that's a given. But also always anchored, particularly in a department like this, into the realities and the pressures of the people that we are here to serve. Oxford Excellence, as our new campaign development slogan boldly states. When I hear Aziz speak about the department strategy, which we went into a little bit during my visit to the department, improving health, transforming lives, of course, I admire the clarity of vision, the courage. It doesn't shy away from the realities of what's facing the NHS, and it sets out a confident, constructive path forward, despite the challenges and the realities that has been set forward. Clearly wanting to strengthen community-based care, prioritising, of course, prevention, harnessing the digital innovation that we're trying to do, again, across the entire collegiate university, but to do that in a responsible way and to ensure sustainability. And these themes clearly resonate far beyond this department. Across the health system, there's broad recognition that care has to move closer to the communities, and that prevention must be central, and that innovation has got to be evidence-led. So the research that we have just heard, of course, aligns very powerfully with that wider direction of travel, which I do believe is a template for many of our departments in the medical school. So it's right and fitting that this ambition, our ambition, is now being recognised at the highest level internationally. And I was so thrilled when you emailed me the other weekend to say that the designation of a WHO collaborating centre, it's not just a ceremonial honour, it is the WHO boldly saying, we trust that this department is here to help shape how the world thinks about primary care evidence. So congratulations to everybody that's been a part of that. Similarly, the strengthened relationship with the Foundation, Dr. Sadak Basra, who I had the joy of meeting in your inaugural lecture, Aziz, that has been so instrumental in supporting primary healthcare in Tunisia, demonstrates just what sustained global engagement looks like in practice, investing in the leadership, building the capacity, and developing educational pathways for the next generation. So important, and of course, in the DNA of what we do here as an academic teaching and research institution. And of course, primary care sits at the very heart of this. It's where prevention is delivered, it's where long-term conditions are managed, and it's where inequalities are sadly most visible. So if we are really serious about building fair, resilient and sustainable systems, primary care has to be at the epicentre of all that activity. And it's got to be informed by robust, evidence-based data. At the same time, the connection between health and prosperity has never been clearer. A healthy population underpins productivity and national resilience, and sustained prosperity depends on a strong research and innovation base. And universities like Oxford, we have a responsibility to contribute constructively to that relationship through discovery, through our partnerships and through our impact. And in that context, of course, our role within the Oxford-Cambridge Growth Corridor is of enormous significance and could not be more timely. As many of you know, I grew up not very far from here. I trained here. I've spent most of my career here. So when I talk about the Oxford-Cambridge Growth Corridor, I'm not speaking in abstract policy terms. I'm talking about the places and communities that literally made me. And this region has an extraordinary concentration, as we all know, of research and talent and enterprise. And our responsibility is to make sure that potential reaches outward into the NHS, into the communities across the UK, and into health systems that need it most around the world. I've spoken previously about the importance of ensuring that growth of this kind is both ambitious and responsible. It supports infrastructure, skills and opportunity, and it delivers benefits not only nationally but for the communities in which we operate. And that is why we launched over the past academic year Equinox, for Equitable Innovation Oxford. We are going to build a different innovation ecosystem that doesn't leave people behind and where everyone can benefit. Lord Vallance has been a strong advocate for this agenda and many more. As he knows, I've said before, I count my lucky stars each and every day that we have Patrick at the heart of government, because he remains a fabulous champion for the sector, and he has been pivotal in all the background negotiations that have got us back into Horizon Europe, on the Erasmus programme, and of course the Oxcam corridor, as well as many other things, including the Oxford Growth Commission, and indeed the wonderfully welcome further investment that was announced just this week by Rachel Reeves. He recognises that scientific excellence, regional connectivity and sustained investment are essential if research is to translate into meaningful economic and societal impact. And what we've seen today, and you are doing, is exactly what Oxford's contribution to that ecosystem should look like: rigorous, applied, globally connected and firmly rooted in the communities in which we are trying to serve. And that, of course, brings us to this evening's keynote, Science for Health and Wealth. We are so fortunate to have here with us Lord Vallance, who understands these connections at the highest level. He needs little introduction, but I will say something specific rather than just listing his countless credentials. During the pandemic, when the pressure to say more than the science could support was no doubt immense, but he didn't. That kind of discipline, holding the line for evidence when it's genuinely hard to do, is rarer than it looks, and for that, the country is eternally grateful. Lord Vallance has served in academia, in global industry and in government. As Chief Scientific Advisor during the COVID-19 pandemic, he demonstrated the importance of evidence-based information decision-making under extraordinary and unimaginable pressure. He now serves as Minister of State for Science, Innovation, Research and Nuclear, helping to shape policy at the intersection of science, growth and national resilience. Few individuals have had such direct experience of how scientific leadership, institutional strength and public trust come together in moments that truly matter. Patrick, we are genuinely delighted to have you with us this evening. We're very much looking forward to hearing your reflections. Would you please now all join me in welcoming our Lord Vallance to deliver his keynote lecture.
It's a great pleasure to be here. Thank you so much, and thanks as is for inviting me. Because you showed the picture of Desmond Tutu, I thought I'd actually start with a quote, one of my favourite quotes of his, which is, "Differences are not meant to alienate or to separate. We're different from one another precisely in order to recognise our need of each other." And I think there's no truer quote for research either, that is exactly why we need to have diversity in our teams. Now, I don't think this audience needs me to explain that there is a relationship between health and wealth. The poorest people in the UK have a life expectancy which is nearly 10 years lower than the richest. If you look at disability-free life expectancy, that gap is even bigger. And at any age, the poorest people have more multimorbidity than the richest people, and it starts younger. There was a report that one of the last things I did as Chief Scientific Advisor was to produce an evidence paper on this for the Department of Health. But that's not what I'm going to talk about tonight. I'm going to talk about why science and innovation drives both health and wealth. And despite the fact that I've spent most of my career worrying about evidence and data and making sure that things are entirely rigorous, I'm going to use a bit of anecdote and some personal stuff as well tonight. I'm going to start here. I qualified in 1984 as a doctor, and the decade before that had seen gastric surgery wards for peptic ulcer disease gradually disappear because of the introduction of H2 blockers to suppress acid. So those wards were no longer needed. But the story I want to tell is when I was a registrar in the 80s, and a young man came into A&E, and he was in his late 20s. He was scared, he had a temperature, he had a cough, and the x-rays showed shadowing in his lungs. And we knew that he would have pneumocystis pneumonia, that he had AIDS, and he was going to die. And he knew that too. It's remarkable, if you fast forward, if you have HIV infection today and you're treated, your life expectancy is roughly the same as the general population, and indeed for young men who get it and are treated properly, it's slightly longer. That is an absolute miracle. And if I think about other areas, oncology, cancer was a death sentence. It's not anymore. It's often a chronic disease and in some cases is cured because of medicines that can target specific genetic defects, because of things like the advent of immune therapies to unleash the immune system to fight a cancer. Heart attacks. People would come into hospital, spend 7 days in hospital. We didn't really have that much that was going to change their outlook. But during this decade, clot-busting drugs from work done actually here in Oxford showed that streptokinase work, plasminogen activator works, you could actually break down the clot that was causing the problem, and that led to a complete change in the way that disease was tackled. And it wasn't just very acute diseases. I did an asthma clinic in those days, and we knew that we had a small group of patients who was going to repeatedly come back with asthma exacerbations and led very disabled lives as a result of this. We would treat them with steroids. It did something, it didn't do enough. And I was reminded of this a few months ago when I bumped into Neil Kinnock in the House of Lords, and he's, by the way, he's given me permission to tell this story. But I came up behind him and I could hear he was wheezing, and I said, "Are you okay?" And he said, "Well, not really. I've got very bad asthma, but I'm about to go on these new biological things." And I was involved in the biologic development of the first biologic for asthma, mepolizumab, IL-5 antagonist, which has dramatically changed the outlook for these people. I saw him a couple of weeks ago. I said, "How are you?" He said, "Transformed." You know, lives are being transformed by medicines, and we can't forget the impact that medicines have had on individuals and on the practice of medicine. Now, of course, it's not just medicines. Public health's had a big impact over this period, and the smoking ban had a very dramatic effect very quickly on myocardial infarction. It's quite extraordinary, the speed. Within 1 year, you could see the decrease in heart attack rates because of the ban of smoking in public places. I don't think anyone expected that to work quite that quickly. And if you look actually at the overall incidence of heart disease, it's gone down 40% over that period due to smoking ban, due to statins, due to a number of lifestyle changes. But not all public interventions have worked. Obesity, which is of course a disease that in itself is bad, but it causes other things. It causes diabetes, it causes heart disease, it's an increased risk factor for cancer, it causes an increased risk of arthritis. And if you look from the 1990s through to 2019, you can see that the prevalence of severe obesity in both men and women in this country has been on a relentless increase. And so we have to conclude that our public health measures have not really worked. Now, you could argue that without them it would be much steeper, and that may well be true. But we know that some countries have managed to use public health interventions to get this down, but we haven't managed to do it. And recently, there has been a dramatic change. Now, I'm not going to ask people to put their hands up, but I bet you there are some people in this audience who are taking drugs based on research from the UK, based from the work to understand that actually the notion that losing weight is all about willpower is sort of skewed by the fact that you've got some pretty powerful signals that come from your gut to your brain that tell you not to eat anymore, and that's different in different people. Therefore, it's not really willpower, it's a matter of whether there's a chemical signal which makes it more difficult for you to do it. And that was demonstrated through work on leptin, and of course then the work of Steve Bloom on GLP-1 that's led to the latest group of drugs that have come out. And I'm struck by the people I meet, often very senior academics and doctors who tell me, for the first time in my life, I can actually control my weight. And they're doing things like microdosing and intermittent dosing and all sorts of things to play around with this. MHRA, please shut your ears on this. But people are doing that. We know that's going on. And that is doing something that they couldn't do on their own. So what's happened? Well, this is what's happened. There's been a massive increase in the use of these drugs. And around 3.5 million people meet the criteria for the drugs, and about 1.5 million are using them, with 95% of these being accessed privately. That is a huge issue for equitable access to medicines and how to think about prevention. My great friend Chris Whitty said a couple of weeks ago that relying on drugs to stop obesity would be societal failure. And I agree with that. What, of course, the newspapers didn't report is he went on to say, but the drugs are very important and we need to work out how to use them in the right population. And so this question of where this fits into the overall management and how we use drugs is going to be incredibly important for this area where we know we're going to need to tackle right the way across the population. It's not just drugs. MedTech is increasingly important for outcomes and changing clinical practice, whether you go back to hip replacements, whether you think about the advent of cardiac catheters, the way in which AI is going to change and is changing radiology, the reading of x-rays, or indeed the diagnosis of dermatological conditions and many others. We're in a period of extraordinary change. When I became a minister, I dropped all of my other commitments apart from one, which is to chair the trustees of the Queen Elizabeth Prize for Engineering, which is the world's most prominent engineering prize. And this year, the prize went to modern neural interfaces. And it's worth reflecting that cochlear implants have made nearly 1 million or over 1 million people worldwide hear who couldn't hear. Deep brain stimulation has radically altered the outlook for some patients with Parkinson's and other diseases. And we are now looking at the possibility of people who couldn't walk because they're paralyzed being able to walk because of the ability to tap into the brain and make those signals understood by muscles. All quite extraordinary things that are going to change the outlook for patients. But none of this comes cheap. So how do we afford this? Well, the first thing to say is it does cost money, but so does ill health. And this is from the NHS Health Innovation Network, and I'm not going to get into whether the numbers are exactly right or not, but the point is clear, that actually there is a huge economic cost of not getting this right, whether that's the overall employment rate, people who actually couldn't work because they're too sick. That's what it would have been like with HIV, it's what it would have been like with some cancers. It's now something that you can actually increase the employment rate, you can stop the absenteeism from those who are in employment, you will obviously lose fewer people to early death, you get in-work productivity up, and you'll get contracted hours increase. So right the way across the board, there's economic gain from getting this right. But that's generally not how we think about the affordability of healthcare interventions. We tend not to think of it in these broader economic terms, but we think about it in terms of a narrower health economic question. And one of the questions that's asked, which is a legitimate question, is does innovation reduce costs? Well, NICE was set up 27 years ago, and the aim of NICE, and NICE has been hugely influential right around the world, was to say there are so many new things coming along, we cannot afford all of them. We must choose which ones make the biggest difference, and we must be prepared to say no to those that don't, and yes quickly to those that do. And when we say yes quickly, we must ensure that there is ubiquitous uptake across the population, across the UK. Actually, it was England and Wales at the time. But that was the idea of NICE, and it's an extraordinary idea that led to a real control of spiralling costs, and it's been very effective. But whether it's exactly right going forward, I think, is a good question, and I just want to illustrate 3 points. The first is, can you actually realise the cost saving? And I'm going to give you an example from when, many years ago, I was in charge of ensuring that we got this question of what we buy and what we don't buy right in UCLH. And at that time, low molecular weight heparin had just become available. And what you used to have to do for someone with a deep vein thrombosis was admit them to hospital, put them on warfarin, treat them with heparin until the warfarin worked, try to get the warfarin dosing right. They'd be in hospital for 3 or 4 days, and that was obviously an expensive procedure. They felt, what the hell am I doing here, because they didn't feel very unwell, and it was difficult. Low molecular weight heparin allowed you to do it as an outpatient. They go straight home, and it's very easy. So for me, it seemed like a no-brainer that we would want to have this drug as soon as possible available at UCLH. I had to go and speak to 100 or so local, I can't remember what the system was at the time, anyway, the commissioners or whoever from general practice and elsewhere who were determining what could be available. And somebody put their hand up after I'd given the presentation and said, well, you say you're going to save money because the patients aren't going to be in the bed for 3 or 4 days, but somebody else is going to be, so that doesn't save any money at all. And it's sort of mad, but of course it's also true. The second one is the problem of annual budgets. In 2011, the drugs that could treat and cure hepatitis C became available. Hepatitis C causes cirrhosis, causes liver cancer, leads to long-term healthcare needs for people with hepatitis. The idea that you can cure it was remarkable, and I think really you could argue this is one of the very first times any pharmaceutical product cured something. But it cost $84,000. And at the time, this seemed completely outrageous, and it was unaffordable. It was unaffordable in year. Not long after the drugs came out, the WHO said, we will eliminate hepatitis C from the world by 2030. That was an achievable goal, but actually, it could have been achievable 5 years after this, if only you could afford the drug. So one of the questions is about annual budgets. If you had a different system and you said, well, I'll pay for that drug over 10 years, and if it stops working, I won't pay for it anymore, you might have been able to do this very much quicker. We finally declared in the UK that hepatitis C had been eliminated a few years ago, but it definitely could have been faster. Would that have been a bigger benefit for the UK had we done that, and how would we do that? And then the final one was, well, can we look at countries across the world and ask, can we learn whether innovation reduces healthcare costs? Well, in the UK, about 11% of GDP is spent on the NHS and healthcare. In the rest of Europe, it's around 12%. Probably the most innovative country in the world, the US, spends 17%. So you might look at that and say, well, that's a bit against the idea that innovation reduces healthcare costs. But if you look elsewhere, and another innovative country, Singapore, where they have very good healthcare, very innovative healthcare, the total healthcare cost to them is 4 to 5% of GDP. So the answer is it's not clear when you look across countries as to whether this reduces cost. Let me move now away from healthcare for a minute and just talk about the notion of science and technology being important for economic growth. The report from Mario Draghi said if we exclude the tech sector, EU, and by the way it's the same for the UK, productivity over the past 20 years is broadly the same as the US. And if you look at the graph below from the Tony Blair Institute, looking at the S&P 500 with the FTSE 100 and looking at the price to earnings ratio of companies, you might not be able to see the grey line at the top, which is actually the key line, which is the US, far outstripped the FTSE 100, far outstripped. But if you remove those tech companies, it's basically the same. So you don't get above average growth if you don't have science and technology companies. That is a very clear message. So we ought to be really good at it because we have great universities, we have fantastic science and tech in this country, we have a long history of discovering things. In the past decade, we've been really good at startups as well. 29% of all the science and tech startups in Western Europe or in the UK. We have more venture capital funding than anywhere else in Europe. We're doing well on startups, and there's definitely a culture which is different. And many times when I go into universities now and meet postdocs, a lot of them are talking about the companies they want to start or the ones they want to go and work in. So we're doing well there. I'm going to argue we're still a bit undercapitalized on many of those. But where we fail, and where as a country we have failed for at least 50 years, is scaling those companies into sustainable, large, successful companies that will export and create wealth. Indeed, if you look at it, we get most of our companies bought at that stage and they go somewhere else or they move somewhere else because they need a headquarters in a different country where they can flourish. That's a big problem for us that we need to fix. So what are the reasons that we're failing to scale these companies? Well, there are lots of them, and I'll illustrate some, but I just want to go into one particular area, and that's money. If you look at the relative funding in the sort of bluey column against the green one, this is the US in blue scaled to UK GDP, so it's trying to make it like for like in terms of the amounts. At the angel and seed funding stage, we're not far off what the US does in terms of funding. At the early venture capital, we're less, and at the late stage, we are much less. And in fact, we're even much less than this graph shows. We're about 8 times lower at least, and in the big rounds, we don't do very well at all. So we are undercapitalizing our companies at that scale-up stage by a long way. If you ask, well, where does the money come from? There's an even more striking picture. So yellow is US, blue is UK. At the seed fund round, lots of the money is domestic capital. As the fund rounds get bigger, most of the capital comes from overseas, and most of that comes from the US. So not only do we have lower amounts of money, most of it comes from overseas. In other words, it doesn't come back in the full way into the UK. There's a little green bar on the column at the end, which is Canada. And I suspect, I don't know for sure, but I suspect that's largely taken up by Canadian pension funds who invest in UK science and tech companies. And I think it's a very striking observation that Canadian pensioners have done very well out of our science and tech, and wouldn't it be nice if UK pensioners could? And that's precisely what's behind some of the measures to try and get the pension funds to release capital into this area, which is higher risk. It does come with risks, but it comes with greater growth potential and is crucial if we're going to develop this system in the UK. So that's one of the things that the government's trying to do to unlock that capital and to make sure that things like the British Business Bank have got more money to be able to put into companies to de-risk this. So you can de-risk the private sector investment. We need to do more of this, we are going to do more of it, and we need to have scale-up funds that focus on this particular area. So money definitely matters, but it's not the only thing. And when I was Government Chief Scientific Advisor, worked with the then government on the science and technology framework to say, if we're going to think about companies, we can't think about single magic point interventions. We need to think about everything that we need to do, from skills to infrastructure. You know, what's the compute infrastructure we need to support companies? What other things do we need to have in place? Scale up infrastructure. To regulation, and that's why we started the Regulatory Innovation Office, to try and pick on these regulations that get in the way and undo them. And you've seen some of that over the last few months, as we've talked about that in a number of areas, including nuclear. Of course, it's about releasing capital as well. But it's also about something that I think is incredibly important if we're going to succeed in this in the UK, and that is procurement. Companies that are growing will only really unlock major private sector investment if they have a customer. Government spends 400 billion a year procuring things and is not good at procuring from SMEs, and is not good at procuring the higher risk innovation. That is an area that I think is really something to target. It's something that we are targeting, and you will have seen perhaps this week 2 announcements which are really about procuring innovation. One for nuclear fusion, to say we will build a nuclear fusion plant in the UK and therefore we anchor ourselves as a customer. One for quantum, whereas in addition to the research funding and the manufacturing support, we've said we will buy a quantum computer at scale when you have one. And there's £1 billion in the next spending review already committed to say, yes, we'll do that. And that's already galvanized companies to think, well, we want to do that. What do we need to do to be that company? This is what unlocks private sector investment, to allow people to come in and say, we'll back those companies because the government's going to buy that computer at scale and they've got a customer, so we know our investment is more secure. So procurement is incredibly important, and if there were 2 obvious departments to go for, and Spencer Livermore, the Financial Secretary to the Treasury, said this over the last weekend in The Guardian, you'd go for MOD and you'd go for the Department of Health, the NHS, because those are very big procuring organisations where innovation really matters. So we can't be successful, we can't grow more than average if we don't get this right. I want to return now to life sciences. The life sciences economy is an important part of this. It's a big part of what we do, and we're successful at it, and we've got 2 very large international companies here. It employs about 360,000 people, generates a very large turnover, and the jobs it creates are higher than average in terms of the pay. If you look at AstraZeneca, it was a mid-sized company, not really doing very much at some point. Because of innovation, because it focused on innovation, and because of those medicines that came out are really important for patients, it's now the biggest company in the FTSE. It's worth over 220 billion. It's created a lot of wealth generation for the UK. So we must do what I've just said in the life sciences sector in order to grow this important part of the economy and to make sure that as a country we're successful. It's crucially important. And that's why these 2 documents together make sense together. Wes Streeting has said the Department of Health is an economic department as well as a health department. That's an important statement. But the 2 documents, the 10-year health plan and the industrial strategy life sciences sector plan, are about trying to get these things moving in parallel. The 10-year health plan has lots of points, but basically it says we need to move from hospital to community. We need to move from analogue to digital, and we need to move from treatment to prevention. Those are all things that require innovation. The life sciences sector plan has 27 recommendations, but it says we must be world-class at the R&D and the trials points that were raised earlier on. We've got to be great at clinical trials. We've got to make sure that our regulatory agency, which it is now seen as one of the best in the world in terms of being able to move quickly. We've got to be good at starting and growing companies, all the things I've just talked about, and we must be good at adopting the innovation in order to create those customers. So these are key linked documents, and a lot is happening to try and get that moving, to see these things moving together. And we are fundamentally a maker, not just a taker of innovation. And we should be really pleased we are, because that's a growth story for the UK. We need to use all of the tools in the science and technology framework to make that happen. And that includes making sure that we have infrastructure like the point that was raised on the Health Data Research Service, something that allows us to access, use and gain value from the data we've collected in fantastic cohorts in the UK over many years. We must make sure that we unlock the capital for this area in particular. We must make sure the regulation is right. We must make sure that the NHS as a customer of innovation is a first customer, not a last customer. And the number of companies I've met, SMEs, that say they've got something good, it's gone through some regulatory approvals, it's being bought and used in Germany or France or the US or somewhere else, and not here. What's the conclusion? They're going to move, or they'll be acquired and go somewhere else. So we have to get this right. That means thinking about our budget for how we procure in the NHS differently and linking it to benefit for patients and benefit for the economy. Let me stop by going just 2 last slides. I've talked about how we should think about things, and I've mentioned this point already, that it's actually a different era we're in. And I started giving a talk about 10 years ago, say, called The Era of Cures. And the reason I did it was at GSK at the time, we had just made the world's first cell and gene therapy product and got it approved. And that, the lawyers would never allow me to say it was a cure. But in effect, it was a once-off treatment for children with a very rare disease, and it worked. I've already talked about the HCV example, and we know there are examples in cancer. These are incredibly important advances, but they're going to put a very important strain on healthcare resources if we don't manage the model properly of how we're going to pay for this. And I've already alluded to models like amortization and other things which allow you to get upfront costs down and spread it over a longer period. This is a challenge. There's also a challenge for how you think about the costing of preventative medicines, of which there are many. My final slide is COVID. And I don't want to go through the whole thing, and today the reports come out for the 3rd module of the COVID inquiry, but I do want to pick on one bit of it, and that's the vaccines. Of course, a lot of work went on in vaccines here in Oxford, incredibly important, but the country as a whole did well in terms of making sure we got vaccines early. Why was that possible? Well, it's possible in part because we had a skilled workforce here who understood what it meant to try and not only discover a vaccine, but to manufacturing and turn it to products. In January 2020, it was obvious that we must go for vaccines. And I was able to pull people in from companies because I knew them and get people from GSK and AstraZeneca and other big companies to come and help define what we needed to do to look at this. That's only possible because we had an industry in this country. The Oxford vaccine could only be scaled because we had a company that could scale it and turn it into a product that could then be used around the world. We could not have done that without a flourishing private sector in this country. And so my final point is that not only does science and innovation benefit patients, it benefits the health service, it benefits the economy, and it's crucial for national resilience and indeed for defence. And I will end with a quote from Alex Younger, who is the ex-head of MI6. And Alex has spoken often about this, and he says, we need in this country to develop strength through technological innovation. And he argues that the security and his life in the security services has changed dramatically because of innovation and because of science and technology. And it's as true in life sciences as it is in digital. This is a contested area around the world. Our strongest way to have defence and security in this country is to have a thriving private sector in this that's able to mobilise to do the things that we need. So science and technology drives health and wealth. Thank you very much. Okay, fine. Yeah.
Patrick, that was predictably absolutely fantastic. Thank you so much. Such great food for thought. Patrick's very kindly agreed to take questions, so we'll allow sort of 5-7 minutes of questions. If anybody has one, please put your hand up and we will deliver a roving mic to you.
Well, Patrick, since I'm first up, can I just say thank you very much indeed for a really telling and important presentation, and it's really great to see you here. I want to ask you about the health and wealth point of the presentation. And now that you are in the front line, the front bench of ministerial life, I want to make it a slightly political question, if I may. Can you see a situation in the future where this argument could be communicated to voters, and for voters to see that health is not just a personal and a community story, but also a supply-side advantage to the overall economy? And can you see a glimmer of how politicians can somehow communicate that and turn it into a doorstep electoral advantage?
Well, thank you. I'm glad you understood the lecture. Because that is exactly the challenge. This does need to be, I think, something that people care about, and they understand that this is a benefit to the UK if we get this right. I don't think that's an easy message to tell. I don't think it's easy to say we're going to spend more money on pharmaceutical products or some other product because people think it's being taken away from something else. And I'm arguing that's not the case. It's actually rather fundamental if we're going to get this right. Those are not easy messages, but I think they are ones that we need to keep talking about and demonstrating that this is crucial. I think the success of the vaccine programme in COVID was entirely dependent upon the fact we had an industry in this country. We could not have done that without that. And I think Alex Younger's points illustrate why this is important. So I think there are many ways in which we can start doing this, and we do need to start having these arguments. They're never easy, and you always get into the sort of, well, where's the money coming from? And the answer I have is I think we need to do it within the healthcare budget because this should be a priority if we're going to be successful. One final point is innovation fails very often. And if we view failure as a stupid waste of public money, we will never do the things I'm talking about. And I'm really pleased that the Chief Executive of the National Audit Office, the Chair of the Public Accounts Committee and the Chancellor have this week written around Whitehall to say, we want you to procure innovation, and we understand it fails more, and we understand that that goes wrong sometimes. And when it goes wrong, that's not a failure of public money, provided we're looking at it as a whole and a portfolio, which I think is a very important step.
Terrific. Great. Let me take this, Jen.
Hi, I'm Leonard. I'm a medical oncologist, and I lead the UK Cancer Vaccine AI project. First, I'd like to say I really like the medical angle that you brought to this talk. And my question is, Oxford University was one of the first to give AI tools to our students. And I'm seeing now that doctors are learning twice as fast as they ever used to do that. And on top of that, our PhD students are doing in 3 months what used to take a year. My question is, have you thought about how use of modern AI tools will start to impact on medicine? Has the department thought about that?
Well, yes, and I'm sure there are people here who know far more about that than I do, and I'm sure you're one of them. I think it's going to have a profound impact on medicine, and I start with a very simple way in which we might judge success, which is if AI ultimately gives more time for the human interaction, which is so essential for healing, it's been successful.
Olufunsho Oyesoya. I have a question, but I will start with my conflict of interest. And this is this. I'm notoriously not a fan of Mr. Elon Musk. I don't agree with what he says, but for what it's worth, and for the sake of the excellent fraternity, medical fraternity that Aziz has put together today, I want to ask a question. Given Mr. Musk's recent gospel, and I'm sure you know what that gospel is, should doctors continue to provide prompts for AI assistance, design rubrics to assess AI systems? In short, should doctors continue to train AI systems? I know what the answer is, and I know what you're going to say, but just for everybody to think about it. Because in Mr. Musk's gospel, he mentioned 5 things. The one that specifically applies to us is that in future, there will be no need for medical schools. That's what he said. In future, there will be no need for doctors. AI will see the patient, AI will make the diagnosis, AI will prescribe, and AI will even perform the surgery. To which I added, and pigs will fly.
Well, actually, I think AI will do all of those things, but it won't do it completely. And I think it's going to be very important for the reasons I've just said. I think healing is about human interaction as well. It's going to be absolutely crucial. Do I think that we should help train AI systems? Absolutely, I do. And I think we should have more sovereign ways of doing that in the UK, because it's going to be about trusted data sources, and increasingly it's going to be about specialist AI models.
Let's get a question from back here.
Hello, I'm Amy. I was wondering, from a procurement standpoint, we've heard Palantir in the news a lot. It's a US company with a reputation for being unethical. We have those skills and the resources to build similar systems here. So how can we encourage NHS to invest here in the UK rather than send that money abroad?
Yeah, well, that's exactly what I'm pushing on with this procurement thing, that we need to be better at understanding what we've got in the UK. So the 2 departments I've talked about, NHS and MOD, what I'd like to see happen is we define what some problems are, we work out what the landscape of UK companies are that could contribute that, we can think about what the procurement systems are that would then give offers. We need to start getting good at procuring from SMEs rather than just waiting till there's one big company that can do it. And we need to accept that's difficult and we'll fail sometimes. And that's why all of these things need to come together. And the cultural part of this is really important. Because, if you're in the civil service and you take a risk to procure from an SME and that fails, and the next thing that happens is you're called in front of the Public Accounts Committee or the National Audit Office and you're told you're an idiot for wasting public money, you will never do that again. And that's why those letters are so important. At the beginning of the vaccine programme, the most likely thing was we would not get a vaccine. It was by far the most likely outcome. And yet we knew we had to do it. And we set a target, which was get vaccines for the population by the end of the year. The National Audit Office reviewed that at the end and said it was a fantastic example of public innovation and how wonderful it was. If it had failed, it would have been the biggest waste of public money ever. Those are inconsistent positions. You have to accept that failure is part of it. And that's why I'm so pleased about this letter that's gone out to encourage people to understand that risk.
Yeah, it's such an important thing to get the culture change. Can we have a question from over here, please?
Thank you so much for the interesting talk. I'm Jen Chidord, a GP and academic researcher. I wanted to ask about global health. So in the departmental strategy, and as he's presented, the kind of strong focus on global health in the department that we're hoping to promote. How does that fit with the view in government at the moment regarding, I suppose, what you've talked about, an innovation benefiting the UK, but how do we see it fitting within the global infrastructure? Is it still in the kind of more Trumpian way, just looking at how global health can benefit us, or how's the government looking at a more collaborative, maybe, view of global health? Does that exist or not? And what's the trend?
Look, it's a difficult time because the ODA budget's come down, so it's difficult. One of the things that's happened as a result of that is that for the first time that I've seen, 5 government departments have got together and said we need to spend our ODA budget in a much more coordinated way, and we need to spend our ODA budget together with our non-ODA budget to get the things we want to see happen. So I think that's a good step that's come out of that unexpectedly. I think the other thing to say is, if we get some of this right, and again, I'll come back to the Oxford AstraZeneca vaccine, that was a vaccine for the world. And it was because we managed to do it here in the UK. So I think there is a global health element to this which we can definitely build on and should build on.
That's better. Cameron Bassett to the BMJ. I enjoyed your talk very much. I've got quite a few questions for you, but I'll ask you one, which is that the strategy of the department here is about improving health. And I wondered, when you talk about improving health and wealth, which of those you are prioritising, because it's not really possible to prioritise both of those. And if you prioritise wealth, there is a risk and a likelihood that you end up harming health.
Well, I fundamentally disagree. My point is that the two things go hand in hand. You've got to manage it carefully. And I'll go back to the example I gave of the GLP-1 drugs. You could just make that a complete sort of free-for-all based on money, or you could say we're going to manage that very carefully with public health programs so you get the maximum health benefit. But if we don't procure from UK companies, we're not going to get the infrastructure we need here. So I think they are together.
That was getting into the spirit of the union, so thank you for that. We won't broaden it into a debate and get you either side of these boxes. Patrick, thank you so much. Just one final question then from me. As you know, I've put innovation as a very key platform for the university, and we're doing well. And it's great to be working with you, on the Oxfam Corridor and the Growth Commission and all that, for which we're really grateful, and we're absolutely committed to play our part collectively to really realise the ambition that you've set for the country. What more could we do, though? What would you like to challenge us to do further from the university point of view? And how can we help with the mission?
The Oxford-Cambridge Growth Corridor is the biggest growth opportunity we've got in the country. I think any other country in the world would give their eye teeth, if countries had eye teeth, in order to get hold of that. And one of the things that, when I was asked to take this on by the Chancellor, people said was, well, lots of other places that we need to be looking after, we can't be concentrating more there. We absolutely can be concentrating here, we should be, because if we fail to make this the growth engine that it should be, then we're doing everybody a disservice. We're doing the country a disservice. So we must get this right. That's not at the expense of other places. It's about making sure we build on the successes. And that's why I'm really pleased by the progress that's being made. And two things have happened this week that I'd just pick up on that. One is I met a group of regional business leaders from around the country, and one of the people who came from Oxfordshire said the thing that he'd noticed was that there are many different groups who were all sort of somewhere in and around trying to do something in the corridor were now all working together. That's great, that's exactly what we need. And the second is the announcement from the Chancellor in the May's lecture that there'll be a proposal for an Oxford Development Corporation, which I think is exactly what we need to get this going. We've got one being progressed in Cambridge. We'll need to do things across the middle as well. So what can you do? I think absolutely throw yourself into this idea that this is about benefiting from the startups and the excellent science here, but it's fundamentally about growing that right the way across the corridor and having that view that there are places right the way across there that are going to benefit from this. And ultimately, this is a national benefit. We must see those companies go and grow somewhere else as well. So I think taking that national view as we develop the corridor, I think, is key. And I know you're doing that.
Thank you, Patrick. Yeah, and just for colleagues, if they don't know, we have a memorandum of understanding with Birmingham University and now with the City of Liverpool, which we've signed. So again, really working on just beyond the corridor, how we can place our companies in these other extraordinary cities where they've got the talent, they've got the opportunity for growth We just need the capital again and the regulation to be a little bit easier. So it's great to be working really closely with this, and we will absolutely play our part and keep delivering. We're not short of a pipeline of companies, as you know, coming through. It gives me very great pleasure to ask the other Chancellor of the country to come and give a vote of thanks to Patrick. So, William, it's great to have you here. Please do give a vote of thanks to Patrick. But before William speaks, please give another round of applause to Patrick.
Well, it's a great pleasure to thank Patrick, Lord Vallance, for a speech unusually clear and to the point for a speech in this debating chamber. When I was a student, I spent much of my time as a student in here. It was very kind of Aziz to put up that photograph of me with hair 45 years ago. We once decided it would be great fun to hold the world's longest debate in the history of the world, which we did. Typical Oxford student, ambitious thing to do, which we did, and the rule was that if 100 of us spoke, which we did, as long as we spoke for more than an hour each, we would break the world record, which we did. So everything has been commendably brief and to the point to me today in the initial presentations, and in your speech, Patrick, which I absolutely heartily agree with, and I'm delighted to hear members of the government saying it. May I say, as someone who's served in many governments, it's refreshing in any government to find a minister who really knows the subject that they are talking about, and that is what we have in you. So we are, as the Vice-Chancellor has said, enormously heartened by your presence in the government, your commitment to Oxford and to everything we're doing here that you have just so strongly supported, and to science. And the importance of what you have just said about government procurement, I think, is absolutely central as well. So we're delighted to hear your remarks this evening. You've shown that we've come a long way since the 1980s, since we were having those eccentric debates in here, but that we've not solved everything. You showed that with the persistence of obesity, for instance, and though even there, as you described, the story of the GLP-1s is a reminder of how fast things can move when science and clinical ambition align. And that connection between scientific discovery and patient benefits and economic return is what you've been talking about tonight, I think very persuasively. And it's a connection that's not automatic. We have to make deliberate choices to find that connection. Here we are in the Oxford Union, a forum long associated with debate and conviction, the exchange of ideas, but what you've described tonight goes beyond debate, really, because it concerns the practical application of knowledge to improving national health and to transforming lives. You made the case, I think, convincingly, that innovation in the NHS is not a cost to be managed, but a source of economic return. That the life sciences sector in this country employs hundreds of thousands of people, generates major export earnings, and depends on exactly the kind of research and infrastructure that we have seen on display today in the presentations earlier. And it's also an argument, as Aziz said at the beginning, about sustainability, not just in the environmental sense, but in the deeper sense of building health and science systems that are genuinely designed to last. A nation that sustains that commitment is also, as the pandemic showed, better placed when the crisis comes. The Oxford vaccine did not emerge from nowhere. It came from decades of investment in research infrastructure, in people, in the freedom to pursue ideas whose application was not necessarily obvious at the beginning. And that is a lesson which we all hope has been learned for the future. I've had the privilege of visiting the Nuffield Department of Primary Care Health Sciences in recent months and listening to the excellent research talks from the speakers today. They demonstrated how research connects to real-world challenges and that academic departments such as this are vital in ensuring that such work is thoughtful, rigorous, and scalable. So I hope now that we all understand very well, and you've illustrated very well in your speech, Patrick, that prosperity can't be secured by short-term measures alone. It rests on institutions, on credibility, on knowledge, and on a willingness to invest for the long term. You've made that point in your speech today. Universities and the research they undertake are central to that endeavour, and you've repeated that today. We know, all of us who served in government, the short term often defeats the long term. The pressure to respond to this week's problem rather than invest in the next decade's solution is relentless. But what we've heard tonight is a reminder of the importance of defeating such short-term pressures. The UK's enduring advantage has always been its intellectual capital, its universities, its researchers, its capacity to innovate, and that we must now nurture deliberately and consistently. So thank you so much for your clear and eloquent advocacy of that. The Nuffield Department of Primary Care Health Sciences strategic ambition reflects intellectual seriousness and a clear sense of responsibility, not only to the university, but to the wider health system and to society more broadly. And I warmly congratulate Aziz and his colleagues on everything that they are achieving, and I thank Lord Vallance for a lecture that made a genuinely important argument that a nation which invests in its health is not spending money, it is making money. That's a harder case to make than it sounds, but he made it with precision and authority this evening. This room has, over a couple of centuries, hosted a great many arguments. Some of them have even changed things for the better. And I suspect that what we've heard tonight from Aziz and his colleagues and from Lord Vallance belongs in that category. So it's been a great pleasure to have you in Oxford this evening, and I ask you to accept this very small token of our appreciation for being here tonight. And I would also like to make a small presentation to those who've made it possible to have tonight's event. First of all, to Hayley Smith, the events officer. There she is. I think I got something. Oh, here we are. And to Anna Moore, why don't they all come forward? Anna Moore, Communications Manager, Joe Gearing, Head of Communications, and Rebecca Siriwadene, the Website and Communications Coordinator. And that concludes proceedings. Thank you very much, everybody, for being here tonight for a fascinating evening.